So we will see the panoramic image first. So how to read the X-ray? First, immediately don't jump and see this teeth. Oh, there is a bone loss here. Okay, don't see like that. First, see the sinus. This is the posterior border. This is the posterior border. This is the sinus floor. This is the anterior wall. Okay, can you see here?
Yes.
Here it is moving front. It is aggressively, the pneumatization is happening, and it is going like this. And see where is the nasal floor. This is the nasal floor, right? Here where is the sinus. Sinus floor is very much down, right? It is occupied from here to here. This is the canine, right? This part is the nasomaxillary buttress. This part. Comparatively, this side nasomaxillary buttress is invaded more by the sinus than here. Can we place implant here? No. Right? Can we place implant in 6, mesial root, distal root, 7? No. So, our plan is to place one C3 here. Pterygoid, right? Here, C3 pterygoid. Even the sinus is invading the pterygoid space very much here. So we need pterygoid support, C3. And anteriorly, midline is here, right?
Yes.
Next to midline, one implant. Next to midline, one implant. Okay. And we will place one implant engaging the nasomaxillary buttress. That's it. This is all on 6.
But we do maximum all on 6.
Yes. See, if the problem with this approach is, here we are starting the implant from 4 region. This is 3. Okay.
Yes.
The abutment will be in 4. Here the abutment will be in 8. So it's a long inter-implant distance. This is quite risky. The more the distance between the 2 implants, it is risky. If you do welding here, it will fail because the long wire not flexible. If you place a metal acrylic bridge during removal, if one implant disturbs, then it is highly risky. Then you need zygoma actually. If this implant goes, this needs zygoma. So these kind of complex cases, it is better to use the multi-unit single piece. Okay. We remove the design like this. Okay, place this implant. Okay, so we will see how we plan. So the key area is pterygoid, distal support, right?
Yes, sir.
Middle support is provided by this nasomaxillary buttress area. Buttress area. Anterior support is next to nasomaxillary canal. Nasopalatal canal. It is in the nasopalatal canal is here. Just next to this. So nasopalatal canal next to nasopalatal canal. Anterior support. This 2 implant. This is a very successful design even in conventional implant. See, if you knock out the pterygoid here, it becomes a classic all on 4. But here, the implant emergence is not from 5, it is from the 4. So we cannot give cantilever at all. So better to add pterygoid always. So adding pterygoid, it adds 100%, 200% success into the system. So maxilla planning with multi-unit, this kind of complex case, it becomes simple because it is only a 6 implant.
Okay.
See, in the lower jaw, it is a simple situation, but we use 8 implants. But upper less bone, but we are using only 6 implants.
Sir, like C2 and C3, in we do C2, C1, C2 in mandible, not C3, na?
Yes. C2 is only zygoma pterygoid. Yes.
With the conventional or with the conventional?
Conventional, if you, conventional also you can place one pterygoid. Conventional also we can place pterygoid. Okay.
So
There
pterygoid
are some
comes under
brands they are
basal.
giving special pterygoid design. Norris they are having some good pterygoid implant design. You can place the conventional here. And if the buccolingual width is there, you can place a conventional here, even from 5. Okay. Here from 4 also you can tilt mesially and place one conventional. Anteriorly you have to check the bone. If buccolingual width is there, you can place conventional.
Grafting.
Otherwise grafting or straight away they are doing zygomas. If anterior also no bone, they are doing quad zygoma. Quad zygoma. Okay. So the key is, even if the buccolingual width is very less, even knife edged, if the bone available thickness is only 3 mm height, conventional implant is not possible, right? But basal it is possible. Okay. Because BCS you can use, it needs only 2 mm. Okay. 8 mm, if it is 8 mm is that, you can place 8 mm implant. That is enough. 8 mm, 8 mm, here 8 mm, here 8 mm, 2 pterygoid we have done. 8 mm is a very short implant, but it will serve.
We're talking about conventional.
No. Conventional also they are doing a very good rehabilitation. The only thing is zygoma will come into picture. Yes. See here, the suspense is what is the buccolingual width here. Whether it is favorable or not favorable, we'll see. The buccolingual width will be good here because the natural tooth are still present. There is no problem here. But the problem is in this upper anterior and here, this area. We'll see the buccolingual. First we'll finish the anterior implants. So this is the anterior, almost 1 area. 1 area is all floating teeth. 1 area. So we will measure the length width. It is only 3.7 or 3.8, right? The height is around 10 to 11. Okay. So if you, how will you drill? What implant length you will select? What implant diameter you will select? See, this is a 4 mm implant. If you put 4 mm implant, crustally, right? Mid crustal if you drill, almost half of the implant will be without bone. Only this part will be. So you need to bone graft or they may fail. Minimum 4. Even if you place 3.5 conventional, still till the middle part there is no. So how to handle this situation? There is one technique. If you employ the technique, suddenly the difficult situation becomes an easy situation. It becomes a very easy one. You don't have to worry about this thing which is itself. That is called palatal approach. Suddenly a difficult situation becomes very easy one. Even in conventional they are employing this. Okay. So how? What you are going to do is, we will be selecting a 3.75 implant, but we are not drilling from the crest, we are drilling parallelly. We are drilling like this. Okay. From palatally we are approaching. This is called palatal approach. In basal group they will be taking it as an alveolar bypass. This is alveolus. You are bypassing the alveolus and you are drilling. Okay, instead of drilling like this, you are drilling like this. This is called palatal approach. So what will happen? This implant will be exposed. They are without bone, right? Yes. But palatal soft tissue is very thick.
Yes.
So it is not a problem. Even conventional implant you can do like this.
Abutment.
But will come here. Abutment will come palatally. Yes, abutment will come palatally. Yes. Yes. But that is not an issue.
Screw fracture won't.
No, nothing like that. So what length you can use? Even 11.5 or 10 mm we can use. You see the 360 degree. And accidentally, if you see here, this is a mesodense. Mesodense in the 2-1 area. Can you see? This is the mesodense impacted, completely impacted and fused, ankylosed. So it is not possible to remove. Okay.
So ऐसे मैं ड्रिलिंग करके अगर और इम्प्लांट कांटेक्ट में आता है टूथ में, फॉर एग्जांपल समटाइम्स देयर इज apical 1/3 retented root piece, मतलब
You can leave it, no problem. If it's not infected, you can leave it.
मतलब अगर इम्प्लांट प्लेस करना है सर,
Okay.
तो जैसे ऑस्टियोइंटीग्रेशन होता है हमारा क्रेस्टर तो अगर फॉर एग्जांपल अगर apically थोड़ा अगर कांटेक्ट है तो दैट विल नॉट अफेक्ट द सक्सेस ऑफ द इम्प्लांट. वी कैन गो.
See, as you can see the mesodense here on the left side. So place the implant next to the mesodense or in the tooth area.
Okay.
Okay, even if the implant is touching the mesodense, it is not a problem. Actually, we'll get more good stability.
Okay.
So here also thin, rich, very less high bone, but we can place a palatal approach implant. To implant is done. Now we'll check the pterygoid. So this is the pterygoid anatomy. This is the maxillary sinus. This is the pterygoid junction. So this is our target area. This is where we have to pick our implant, place our implant, like this. See, imagine if the sinus is only till here. So the sinus is only till here. There is lot of bone for the implant to go and guide, but the sinus is expanded till here. So it becomes a tough, challenging situation on the left side pterygoid. So we have to tilt the pterygoid medially also, right? So pterygoid 2 angulations. Pterygoid I will discuss later. Now, see, mesodistally it is tilted 45 degree, right? Tentatively. This is buccolingual cross section. It should be tilted towards the palatal, not towards the buccal. Otherwise, it may enter the lateral pterygoid. Okay. So during drilling, I will explain this. These two angulations are the key for pterygoid implants. If you understand this, it will become easy. You have to tilt it distally, 45 degree. If you don't tilt, it will enter the sinus.
Yes.
If you tilt less, also it will enter the sinus. If you tilt more, also it is not useful. It won't reach the pterygoid. So exactly 45 to 50 around the trace will reach the sinus. Into the pterygoid.
And second,
yeah. Second is towards the palate. Towards the palate. Because if you drill buccally, you will away.
yes.
Okay.
Okay.
This is 8. Sorry, not 8. Yes, 8. After 6 extraction, no, 6 is present, 7 was extracted, 8 becomes easily migrated. Okay. So this is IUPA view. So this is 8, easily migrated 8. From 8, you have to tilt it distally, and this is the pterygoid view. Yes. And see the buccopalatal view. Palatally you have to tilt, right? Palatal tilt and mesodistal tilt. These two tilt. Like PSA is now blocked. PSA, same way. Now we have to plan for the nasomaxillary buttress implant. This is the canine area. Okay. Now we are moving to the first premolar area and tilt it mesially. A very limited bone we are having. So this is the premolar area, distal to canine. They are also very limited bone. Placing a conventional implant will be a very much challenge here. So if you place implant here, like this mid-crestal, same product. No good bone surrounding our implant. So here also what you have to parallel approach like this, like this. Only a 10 mm implant is possible here because as already we have seen, not only alveolar bone, basal bone was also resolved. So this is the buttress area, this area. So this implant is and right side. This is the second premolar. Second premolar is close to sinus, right? This is the first premolar. First premolar is good. First premolar you can place implant. Even you don't, no palatal approach is needed, right? No palatal approach is needed. Just along the root apex, you can go and catch them. This is the nasal floor. So you have to go till the nasal floor. What is the value is? 400, 300. When you go to the nasal floor, it becomes 1000. Around 959. So it is a good one. So from 4, we are tilting slightly mesially because if you place straight, you will enter the maxillary sinus. Just tilting mesially, you are in good bone. So except this right side implant, all other implants are palatal approach. Right? Yeah. So apart from these 6 implants, we cannot place implant anywhere else. That is the problem. So each and every implant should be correct. We cannot make any mistake here. See, I am just trying one implant in 6. Sinus is there, right? Even in 4, it is not present. This is 5, right? So if we try to place implant in between these two, they become very close. Yeah, that we cannot. This is 2, this is 2, 4, 2 10 years. We will see during surgery how it goes. And the other ones are regular. Because the angulation is going like that. If you put even single piece multi-unit, it is difficult to change angulation. So they are doing conventional and they are using a separate multi-unit abutment. You have to use that implants components, impression components. You have to communicate with the lab regarding that. Components will be separate.
You can take impression.
Yes.